thank you, Dr. Vad, and thank you, Dr. Vadva, for inviting me for this talk. And I think right now this talk is very important because we are right now seeing a lot of change in the paradigm, the way we are investigating the patients actually. And definitely the treatment has dramatically changed over a few years. So my topic given to me was the sequential biomarker testing versus the upfront NGS in metastatic non-small cell lung cancer. So currently, what we are doing on in our clinical practice, routine clinical practice, is that we go for the single biomarkers, EGFR, ALK, ROS, and PD-L1. So these are the commonest 4 biomarkers what we normally go for. But there are a lot of challenges with this approach. Definitely it is a cost-effective approach, but a lot of challenges. And what we understand that sequential testing leads to high tissue depletion. And by the end of 4th test, 50% of the tissues are depleted. So there is nothing for us to investigate further. So that's a major challenge. And as per the NCCN guidelines, we are supposed to investigate few more biomarkers which are not routinely available in the clinical practice, so in the clinical laboratories. So for us, it becomes very difficult to just limit ourselves to just EGFR, ALK, ROS, and maximum PD-L1. And the important aspect, what is the wastage in time? So sometimes there is practically the lab takes their own sweet time to do sequential testing. And even the guidelines are recommending the broad molecular testing technique, including the CAP, and which can not only pick up the EGFR, but also the other mutations like BRAF, KRAS, HER2/neu, MET, and copy number alterations of MET and HER2/neu, and rearrangement. So if we go with the sequential aspect, we may not be able to pick up all the different classes of mutations in all the different genetic genes. And even in the ASCO educational book, for situations when we have a limited samples or the tissue is very limited, the NGS is recommended. So we have a robust support coming from the pathology-based guidelines and the clinical guidelines to go for the broad molecular-based techniques. So if you use a single sequential biomarker, even if you really want to do it, even with the gold standard like FISH, they can miss 35% of the ALK translocation. So that's a big cohort which we are missing. And if you go with the NGS-based approach, which are currently available, and which is with the hotspot approach, you may still miss 17% of the EGFR cases. So definitely, these things can be overcome by the comprehensive genomic profiling, which is a higher version of NGS, where all the introns and exons and intron-exon boundaries of the whole gene is being analyzed. So this is a study which was published by Shirok, and which talks about that patients with EGFR 19 deletions may, which were negative, were able to find more mutations in the EGFR, and then they have some benefit with the EGFR inhibitors. So this is again a point which we just discussed, that the standard of care EGFR testing sometimes may miss, and which we need to investigate further. In terms of doing ALK translocation by FISH or by HC, which is a routine clinical practice, but we are not able to find out the partners of the ALK translocations like EML4, TFG, or the variants of EML4I for that matter. V1 is the variant 1 and V3. These are two important variants which are quite common. And variant 1 is more sensitive to crizotinib, and variant 3 is less sensitive or less responsive to crizotinib. So this information has some clinical utility, which is not being evaluated by any of the single sequential biomarker approach, but can be deciphered by the NGS, comprehensive NGS approach. So there is an added clinical value of using NGS-based approach in treatment of lung cancer. Beyond EGFR, as just mentioned, ALK also can be picked up by NGS, more. And patients who are treated based on the NGS-based approach, there may be up to two-thirds patients which were initially negative found to have complete or partial response based on the positivity picked up by the NGS. So there is not only a diagnostic benefit, but a clinical benefit which is quantifiable, and patients may get a more benefit out of it. Similarly, even for the eye translocations, patients who were negative for FISH eventually found out to be positive on NGS. Patients do respond to crizotinib. So NGS approach can not only pick up, but it is a robust technique where you can rely upon and be confident that yes, it is a predictive biomarker of response in the clinical practice. So let's talk about the real world practice. This is data coming from Medicine et al., where they have analyzed almost 5,000 patients who have underwent tissue-based NGS and a liquid-based NGS using comprehensive genomic profiling. And what they found that approximately 22%, that's 1 in 5, may have a targetable genomic alteration. And once you treat them, you may see good responses in the liquid biopsies, that is the purple, and the red is tissue. And there are few scenarios where you may find very good correlation in terms of responses in up to 100% in few mutations. But interestingly, the liquid biopsy can pick up BRAF, HER2 acting mutations, and other MET exon mutations, which can be again targetable, just besides the tissue. And this is the approach where you can not only go beyond EGFR, ALK, and ROS, but the other actionable targets with quite a good clinical utility. So the guidelines recognize the usefulness of the liquid biopsy, especially at the time of diagnosis when we need tumor molecular profiling and the tissue is limited or the patient is unfit for sampling and there is a less tissue. So practically speaking, the liquid biopsy is based on the NGS. There is no way that anybody can do a single test-based liquid biopsy. So once you do a liquid biopsy, not only you get information about the multiple genes, but some additional information like tumor mutation burden can also be picked up on liquid biopsies. So we'll discuss in the next slide actually. So liquid biopsy can complement the tissue-based profiling, and both of them are NGS-based. So combining them is a good idea. There's a lot of concordance, but definitely it can give you some additional information which is not picked up by the tissue biopsies. So the new treatment options in the lung cancers is driven by the biomarkers. And if we see beyond EGFR, ALK, and ROS, there is an important mutation, MET mutation, which is up to 3%, and RET mutation up to 2%, where we have a lot of new drugs coming up in the red column and the MET column. And even the MEK inhibitors are also there, but it's less than 1%. So important mutations which are almost equal to the ROS1 alteration frequency, MET and RET, should be investigated, and the sequential biomarker approach will not be able to pick up these alterations. So if we see the new Geometry 1 trial, which talks about the MET exon mutations and treating the patient with capmatinib, what they have found that the patients who are treatment naive, they respond beautifully with the objective response rate of 68%, vis-a-vis a patient who have treated with 2 or 3 lines, the response rate drops to 40%. So the take home is, early on we investigate the patient with all these rare mutations, you may see a better outcome in your treatment response. That is the take home for this slide. And this is again the tepotinib, which is again a MET exon skipping mutation inhibitor with a response rate of almost like 89% over here, but the average response rate was up to 50% actually. And this led to the approval in Japan, but you can see quite a good, beautiful response with the available drug. Again, selpercatinib, LOXO-292, which is a RET fusion inhibitor, can also show response to the RET fusion gene. But interestingly, all these alterations have been tried in treatment-naive patients actually. And so that is the benefit what you get starting early on. So again, with the trial, phase 1, phase 2 arrow trial, Ferlacetinib can also be used to inhibit the red kinase inhibitor with quite a good response rate. And again, people are looking for the treatment naive population in these scenarios. So let's talk about the new biomarkers beyond the genomic biomarkers. That is the PD-L1, which is a single biomarker which has to be done separately. But PD-L1 definitely favors a response to the checkpoint inhibitors, but it is not an absolute association. So we'll see in the next slide that the patients who have high PD-L1, high TMB definitely show responses to monotherapy of the PD-L1 or the combination therapy with PD-L1 CTLA4. But patients who have low PD-L1 or less PD-L1 expression with high TMB still shows a response to all these immunotherapy. So TMB definitely is a complementary biomarker for response to immunotherapy, and this TMB information can be gathered by NGS only. So this is the data talking about the utility of the blood-based TMB on the liquid biopsy, where patients are being offered atezolizumab, and this is the popular in the OAK study where they have shown responses. And the cutoff used was the blood-based TMB was more than 16 mutations per megabase. Similarly, in the MYSTIC phase 3 trial, the blood-based TMB showed benefit using durvalumab, but the TMB cutoff was used was more than 20. Again, combination of pembro plus minus chemotherapy in this trial showed that the plasma TMB can serve as a biomarker with the cutoff of 16. So this is the data coming from Max Hospital. This is my data which I have analyzed and collated, where the routine clinical practice, this is a case study of almost like 35 cases. Routine clinical practice, the EGFR cross is approximately cumulative of 46%. But when you use the NGS approach, you may pick up additional percentage of targetable alterations, and your 46% goes up to 70%. And these are the NCCN guidelines recommended treatment. If you go beyond the NCCN guidelines, you may get actionability in almost like 97% of the total patients, but these are non-FDA approved approaches actually. So this is the summary where the single platform is compared with the NGS platform, EGFR, ALK, and so you can see the MET, BRAF, RET, ERBB2, and these are all additional information which was picked up by the NGS platform. So this is a case study where a 56-year-old gentleman with a metastatic lung cancer who was found to have EGFR mutation del19 deletion with a single sequential test had a rapid progression on allortinib, thereafter afatinib, and he had T7 enzyme on progression, was on osimertinib. But the patient was investigated using NGS in a retrospect, and what we found that the patient not only had the exon 19 deletion, but also had ERBB2 amplification, which was the explanation why the patient was not behaving as expected on the first generation or second generation or third generation TKIs. So sometimes beyond the targetable, actionable target, what we are looking at, you sometimes get more information on the inherent responses or inherent mechanism of resistance which can be present, you can say, together in the initial steps. So this information is sometimes very helpful. So to summarize my discussion, using NGS will pick up several biomarkers at once. It avoids tissue exhaustion. It saves time. And with the new advent of so many targetable drugs available, so we are obliged to find the best answers for the patients before we plan the treatment for them. With that, I thank you all for your kind attention.
Thank you, Dr. Amit. That was really very, very informative. And I would request the participants to post their questions now. We have time to take a few questions. So for the benefit of our DNB residents in particular, Dr. Amit, could you please sum up as to what you are recommending? Say a case of lung cancer, and let's restrict to non-small cell lung cancer. What biomarkers are you recommending? upfront, and which sample, whether tissue or blood, and which method?
So
you could meanwhile answer this. Yes.
So if there is no cost constraint, I would go with and the biopsy is available, I would have to go with the tissue-based test, a comprehensive NGS, along with tissue IHC of PDL1. So these are two important things which I will go upfront if I have the access to tissue and there is no issue in affordability. If there is no access to tissue, I would go with the blood-based molecular testing, which will give me a lot of information on the TMB status and the genomic alterations. That will be my second tier of investigation if the first is not available. The third, if the patient cannot afford, definitely we have to go with the sequential biomarker. For that case, I would be going for EGFR, ALK, and ROS. I would refer myself to PDL1 because again, cost becomes a constraint for that patient who cannot afford NGS. So, but if the patient can afford NGS for whatever matter, then PDL1 has to be done. So, three-tier approach for a patient of three different strata.
Jyoti, can I make a comment? This is Hemant Malhotra from Jaipur.
Good evening, sir.
Good evening, sir.
Very good evening, Amit. Very nice presentation, and I think your last sentence was very important and relevant. I have seen so many patients in which all the patient's money is expended on NGS and whole genome sequencing and you know what, and the patient doesn't have any money for even generic tyrosine kinase inhibitors. So I think each one of us has that responsibility to keep that in mind. Thank you.
Thank you, sir. So we have a question from Dr. Yama. He is asking, are there errors possible in NGS? Those errors, will they affect the detection rate or the quality of detection?
So it's a very good question, and various errors can happen. When we talk about the pre-analytical errors, it is quite possible, and then you may have false negative rates. You may not be able to pick up the information what was there. So that is one possibility. The second possibility could be the way the algorithms of NGS are being read. So sometimes if the alignment is not done with the reference genes properly, you may see the location of the mutation at a different site, which may be misleading and you may not act upon it. That is second. Sometimes the NGS-based approach is not able to pick up all classes of alterations which include the translocations and copy number variations, but they are able to pick up the point mutation. So you have to be very cautious in terms of what kind of reporting they are doing actually. That is a third possibility. And the fourth possibility is that the types of genes what they're analyzing, are they covering up your whole panel of the expected panel what we're talking about? The hotspots sometimes focus on the few areas, not the whole gene, the all important exons. In that case, we sometimes miss them. So these are the technical limitations which you may have false negative. In terms of false positive, we do not see false positive in NGS that much. But again, it may be a bioinformatics error which can lead to false positive scenarios, and there could be ambiguity or because of the heterogeneity what we see. So sometimes it is better to go with the mutation allele frequency to see whether you are picking very minor clones which may be misleading, and you may just act on those minor clones and you may not see any responses as expected. On the other hand, the tissue-based sequential approaches are less sensitive and they are able to pick up the major clones primarily. So you may see more clinical correlation while acting on them. So again, so we have to see both things together before making any judgments.
Dr. Ved, sir, you wanted to make a comment?
Yeah, Amit, my concern is about the turnaround time as well. You know, you have a patient where there is sometimes an urgency to start the treatment. And then within 24 hours, you can get the PDL1, you can get the ALK, and if you have the RT-PCR in-house, you can get the EGFR within 48 hours. You know, And how do you, if you send it for a comprehensive genomic sequencing, the turnaround time is quite long.
So the point is well taken, sir. Turnaround time is definitely longer than the sequential biomarker because of the easy access in-house access. But you have to weigh the clinical condition. If you have the window where you can manage the patient, I think it's worth going with the comprehensive genomic profiling. And if the patient needs immediate attention, I think the call is all at the physician discretion actually.
Dr. Hemant sir, you had a question too?
Yeah, Amit, suppose you get a comprehensive genomic profiling on a tumor and it throws up 4 or 5 mutations and you have targetable drugs for all those 4 or 5 mutations. How do you decide which is the driver mutation and which targeted treatment do you start first?
So this is the limitation of the overwhelming information what we come while doing the CGPs or comprehensive profiling. So I personally recommend that if you have the known driver mutations, which includes the EGFR, ALK or ROS, you should target them. But if you have a complex picture when you have multiple genes to be targeted, I think in that case, a molecular tumor board helps us out defining what is the what rationale we have to follow. But definitely with this complex information, if there is a case, you should not expect the responses what you normally expect with a single biomarker thing, because you may find a lot of resistance immediately. The drug starts failing immediately. And sometimes the complexity can be deciphered or made easy by getting more information. You can ask the lab to offer us the mutation allele frequency. If the one which is a driver mutation and a higher mutation allele frequency, I think that is a logical thing to target that, and you may see a better control of the disease. That's another approach.
Dr. Amit, in your experience, how often have you encountered such a scenario wherein you see possible drivers?
Yeah, so even in the single sequential biomarkers, we have seen complex reports which include EGFR with ALK and sometimes EGFR with ROS and sometimes complex pictures. And in the NGS, definitely we encounter 1 or 2 alterations which may be targetable, especially if you talk about the PIK3CA mutation, which is quite a prevalent mutation in lung cancer as well. So up to 20% to 25%, you may hit that alterations if you investigate them. So, but in terms of EGFR amplification and EGFR mutations, and along with the HER2 mutations, sometimes you see this quite often actually. But we rarely see alterations like ALK alterations with the EGFR mutations or ROS alterations with the EGFR. So they are practically mutually exclusive, but you may see rare exceptions actually. So, but for all practical purposes, it gives you a very simple answer, straightforward. Yes, this is the key mutation I was looking at, and I got the answer. I should start the treatment.
Right. Thank you for that answer. And one more question from Dr. Bhuvan. Is it possible to detect on liquid biopsy T797S mutation post osimertinib?
Yeah, the answer is yes. So if you talk about the liquid biopsy offered by the foundation, they have 70 genes, which includes the EGFR and all the alterations, so you can easily pick up. And in terms of whether it is cis or trans, it may be difficult, but yes, you may get some answers.